I have to tell something. Actually, it's not a debate. We are trying to find a consensus and compare different approaches in whole of the world.
I concur with that. Basically, the way that we'll try to do it, I'll give an overview of my own experience locally, how I started my own multidisciplinary team looking at the thyroid cancer patient. And Dr. Hujja can give you really how things are done in Germany, and then with some emphasis on really the actual way of looking at thyroid cancer patient. Can I start? Yeah. So let me give you an overview. Actually, in the Gulf area, and that's probably you're aware more than anyone else, that there is a disparity in the way that things are done. You have one cancer center that really has all the specialists, all the tools, and can provide comprehensive multidisciplinary team program looking after patients with thyroid cancer. You have the private sector where really some surgeons are trying to do thyroidectomies and then really leaving patients unattended when incomplete surgery, no follow-up really made for them, and really with poor follow-up. And in between, you have centers that really are trying to make, to look after the most commonly seen low and intermediate risk patient, and to try to provide them with the needed, and then if really complicated happen, to refer them to a more tertiary center. So when I arrived from Canada, actually, although our hospital was said to be the tertiary hospital, but we were far away from the university hospital, which is 3 hours driving. And it was difficult for patients. We used to send patients when they were subjected to surgery to receive radioactivity at the university hospital where the thyroid cancer multidisciplinary program was felt to be present. Unfortunately, patients were finding it very difficult to move. Families had to move all along, and it was traumatic to the families and to the patient. The idea of having a cancer was difficult to start with, to get to the patient, and when the whole family has to be mobilized to support that patient, that was another issue. The follow-up really was really not adequate. We had 2 patients, young patients, who were left really unattended after surgery, with the idea that they were booked but did not show for appointment at the data referral center, and then no attempt was made really to try to get them to call them back. So with that in mind, we felt we have to create something, and that's really where I tried to create something at the hospital where I was practicing. Now, a few issues, as I mentioned, you have few elements really to look after. You have more than one person involved. You have the endocrinologist, the nuclear physician, the radiation oncologist. You have to have the setup to give radioactivity. So based on the local rules, you have to have a license really and the proper setup at the hospital to provide radioactive iodine. Your room should be set in special fashion. You have the wall should be leaded. Physicists have to put a proper plan that will be accepted by nuclear agency. So that was a major task to convince the local health employees that really it's a safe procedure, could be done. The most resistant I had, could believe it or not, I had it from nurses. Nurses really refused the idea that they have to look after really someone who's been put in isolation in that isolation room. But with time, with education, this came through. The other really problem that really we had is really to convince the surgeon that we need really to get someone to get expertise in the way looking after doing those surgeries. So I was really the bad boy for a while by the general surgeon who felt I'm a threat to them, that they feel capable of doing thyroidectomies. The surgeon between themselves, they had also major issues until really we identified 2 people that had the neck surgeon that really were felt that those the one that should be dealing with those patients alone. And then with time, really, people started really respecting that idea and accepting them as really the true referral surgeon to have those kind of patients doing surgery on them. The third issue that really what we had to do is to get everyone together. Okay, the surgeon has a busy schedule, and really we had only like the two of them doing the surgery. The nuclear physicist felt she was also had her own agenda. I could not really get to meet to discuss cases. The hospital was not really in the idea of really dealing with multidisciplinary approach pattern. The oncologists felt too far away and did not want to deal with thyroid cancer patient. So to get everyone really put together was another task, and really it needs really a lot of conviction. And if you convince yourself, you can convince other people. If that's not the case, it's very difficult to pass your message through. But with time, this really built up, and that really was feasible. And then really things really were getting smoother, and we started really getting some really understanding between us and the pathologist and the surgeon and the physicist. So as far as pathology, we adopted really the Bethesda reporting system, whereas before every pathologist used to report their pathology in a different pattern. Like there was no way of really getting a final understanding really what they meant by that reporting. Every pathologist had a certain way of reporting. Then we said that the way of reporting based on standardized and the Bethesda reporting should be the way to adopt. Then we went further on this, and then we adopted the standardized reporting system. So all reporting should be, as really Dr. Nabil has shown you, it should indicate like different levels in the reporting, the type of tumor, was it focal, unifocal, is it T1, T2, T3, whether it's a extension, vascular invasion or not invasion. So the whole picture will be accepted to be standardized and accepted worldwide. So if really that report has to go somewhere else, they understand exactly what really was found during pathology. The last step we did is that we convinced with the surgeon that really we need to use ultrasound a little bit more frequently, and as I mentioned, we started doing ultrasound on every patient going for surgery pre-operatively, so to give the surgeon a good, adequate picture on really the local anatomy before really they go and open and have a look inside. Then, because of the risk of hypocalcemia, we looked at the literature, and then there have been some report that if you do PTH assay immediately after surgery, and the PTH assay is above 10, for instance, that really the risk of really having problem with hypocalcemia is very minimal. So it's really safe to send them home on no calcium or vitamin D replacement. Now, vitamin D, again, that was another issue that, as you know, 99% of women in the Gulf area are vitamin D deficient. So one of the things really we're really keen in making certain is that they are vitamin D replenished before really they go for surgery. And then on that basis, vitamin D they were kept on vitamin D until they come back and then for assessment. So those are the issues that really that I'm sure they are probably common to all of you. Among really that, but really what really that attracted my attention, and really as an ACE chapter, we are really going and starting on a project, and probably will be addressing some of you here to be part of it. We looked at really ask what guidelines are being followed in the Gulf area. We asked actually our colleagues in Saudi at the King Faisal Hospital, which have probably the largest experience in following thyroid cancer patient. We asked them how many thyroid cancer patients they're looking after. Guess the number. Do you have a number how many patients they have been following so far in the clinic? They have 5,000 patients they have been following in their clinic. Did they get any data like to set up their own guidelines? No. They're following the American thyroid guidelines. They feel they are really well established. They are really well proven, so that's the way to do it. But again, we highlighted to them that really those guidelines were based on their own local data. This is not really reflective on really what's really happening within our own patient. If you look at the risk stratification I gave you, okay, most of the staging system were built on a cohort of patients not exceeding 500 patients. Maximum 1,000 patients. okay, that they followed for 4 to 7 years. King Faisal, they have so far, they have 5,000 patients they have been following for the last 10 years. So they have really plenty of material to come up with their own guidelines. And I'm sure you probably, at the Cancer Center here in Kuwait, you probably have something similar in that respect. So we are probably starting really collecting data and really following patients in the upcoming few years, trying to establish our own local guidelines. The other thing really, we felt that really that although some registries are really available, the reporting data to those registries are not very consistent. Some far away areas that really are far from the main city like Abu Dhabi or Dubai, okay, the reporting system is very poor, is not reflective also on really the proper data that really we should be collecting on those patients. So we're trying to do something from that respect. So those are issues that really I wanted to highlight, and I think they reflect probably issues that have been really common to all of you, and then reflecting on my own experience. Probably this is totally different in Germany, in North America, and where really things are a little bit far advanced in the way of surgery is done, in the way that treatment are done, and the way dosimetry is done. So, but one last issue, which really I found that really all of us really were suffering from, is really a study that done by, I think Banaki from Canada. She is a psychologist, Canadian psychologist, that published the study from the American Thyroid Alliance, where she did send surveys to close to 2,000 patients who were subjected to total thyroidectomy and treated as thyroid cancer patients. And believe it or not, the number of really complications, they were not really reported really on the official registries and really hospital records, where the complications reported by those surveys, by the patient themselves, were far exceeding the one reported locally by local hospitals. The most importantly, no one has addressed, a large portion of them have so much psychological impact from the surgery that really was not also reported in any publication before. So as much as we talk about diabetics having social assistance within the diabetic team, social workers and psychologists should be part of really any thyroid cancer program, because really those are a major issue. One single point, I don't know how to explain it. One of the findings that really she found in her survey, this cohort of patients had the highest bankruptcy rate after having been subjected to thyroid surgery and then followed for their own cancer. Why is that? Probably it's a coincidence, but again, indicating really the importance of this fact.
Okay, I'm going to talk about Germany and actually Germany and Austria. We have less problems in Germany and Austria because the nuclear medicine physicians are also thyroid physicians. It is also a part of our residency program. We have to work for 1 year in our thyroid section. It means we performed ultrasound, FNA, scintigraphy, laboratory tests, and all of other tests which a patient needs. And we have to work with surgeons and pathologists together. It is very good for patients because they come to us and they receive in one day, they get in 1 day during one examination all of the needed examinations, clinical examination, ultrasound, and if they have nodules, then FNA and scintigraphy. In Germany, scintigraphy is very important for us. For our patients with nodules bigger than 1 centimeter in size, we perform scintigraphy, and if we see no uptake or indifferent uptake, I mean cold or warm nodule, we are going to perform biopsy, FNA. Sometimes for some specific patients, or if a patient doesn't want to have a fine nodal aspiration, we perform a technetium MIBI scan. It is not, up to now, it's not clear if the technetium MIBI scan is very useful. Some papers showed us a very high negative predictive value of MIBI scan. It means if technetium MIBI is negative, no uptake, then in 97% of the cases, they shouldn't have any tumor cells. But it is actually under debate. Our problem is always with patients with nodules. And in Germany, we have a lot of patients with thyroid nodules, solitary or multiple. The point is we try to FNA all of these nodules which are bigger than 1 centimeter and cold or indifferent in scintigraphy. In each session, we try to take 2 aspiration from each nodule. It means, 2 times each nodule. And we send to pathologist for cytology and also other examinations. If FNA is unremarkable, but we see in our ultrasound specific features which are typically for a malignancy, we send the patients to surgeons. For this reason, we have always each week a session together. We discuss the cases, and after that, the patient also come to this discussion, sit there, and the surgeon and nuclear medicine physician speak together with the patient, because the patient should discuss finally if the operation should be done or not. Otherwise, we are sure that the patient has a tumor. According to FNA, or perhaps a very high thyroglobulin, more than 1,000. Then we have to send the patient to the operation. And after the operation, the surgeon send back the patient to us, and we perform the radioiodine ablation. As I explained you today, for low risk and high risk patients, we perform the radioiodine ablation except PT1A tumors. In these cases, we discuss with the patient. We show the patients which possibility they have. We say, okay, PT1A, according to guidelines, we don't have to do the radioiodine ablation, but with radioiodine ablation, we can perform a better follow-up, and the patient should decide to have or not to have a radioiodine ablation. It is the only exception in our procedures. We try to find a uniform guideline in Germany and Austria. The American Thyroid Association guideline is very good, is very helpful, but we don't have to forget the patients, the patient population in Germany and in Europe actually is different compared to America. In America, as I know, the iodide supplementation is very good. In Germany at the moment, it's also good, but in America, the iodide supplementation is since many years enough, and therefore we have more nodules in Europe compared to America, and they have more autoimmune disease compared to Germany. Every 5 to 10 years, we try to review our guidelines in Germany and try to up-to-date our guidelines. We have also some problems, as I showed you, with iodine-negative patients. It is always the question how we can approach them, how we can treat these patients. And in this regard, we are always in contact with oncologists, especially oncologists who are very experienced in treatment such patients. And we send our patients to these colleagues. They want to have a PET-CT, FDG PET-CT, and a radioiodine scan, because they want to be sure that the patient is radioiodine negative and FDG positive, then they start to treat the patients, and we do the follow-ups.
So basically what we're trying to say is that really is looking after thyroid cancer patient is a multi-task project that involves more than one person. That really probably this should be the pattern that really we all should have to adopt really for the proper follow-up of patients with thyroid cancer. We need really to study our data a little bit more than really been done so far. If you look at the increased incidence of papillary thyroid cancer, it's true. It's probably largely pushed by the use of ultrasound. We're detecting more thyroid nodule. But remember, the Chernobyl accident really where really the incidence of papillary cancer increased 80 times more after really that accident. And if not to go into sensitive issues, but again, it's open for everyone. I was looking really to see why the incidence increasing in the Gulf area. And by coincidence, I went to the CIA site on the internet. And it's clearly indicated that during the Gulf War, missiles, the head of missiles were charged with uranium, which really is in the soil of the Gulf areas, which means we're going to have really exposure to radiation for hundreds of years to come. And the incidence of thyroid cancer, specifically papillary cancer, is going to increase, not only because of the use really of ultrasound, because we have really another causing factor that really is being put in perspective. And that's why there's a need to have proper data on really the incidence and the prevalence of thyroid cancer within that region. So there is a lot of work to be done, but again, nothing could be done without really concerted effort from everyone. To believe in the same idea, the same needs, and to use the same pathway to find really the proper way that where the patient will benefit at the end, not anyone else. With this, really, I think we said everything. We're open for questions if you have any questions, maybe or personal comments, personal experience from the States, actually from USA, if you have your own background, from personal experience that you have yourself, would be great to hear your feedback. That will be quite useful.
Any additional perspectives? Sorry.
Surgeon, by the way. For instance, we meet thyroid much more than we used to see before, papillary carcinomata or others, but mainly papillary. I have never before the invasion seen any case of multiple sclerosis, for instance, in a Kuwaiti patient. When I was very young, our teaching was there is no MS east of Suez. Now, in the ENT department, not in the neurology, we see it very frequently. They come with vertigo to us, and then we discover they have MS, and then we send them to the neurologist. Only after the invasion. Before the invasion, I have never seen it in a Kuwaiti. Now, there is an association for the multiple sclerosis patients in Kuwait. So I think what you said, the number has increased. I don't know statistically how they didn't notice that, but it is there. This is number one. Number two, we have a problem. When I was young, only the surgeons, the general surgeons, performed thyroidectomy. Now, after all these years, in the last 15 years or so, we started getting colleagues from the ENT department. They are trained in Canada. Most of their work is thyroid. We still, the surgeons, general surgeons, are still doing it. Although the head and neck area is our area. Unless you are really specialized in thyroid, you should not perform it. We get bilateral vocal cord paralysis so much from general surgeons. Nobody uses a monitor, a nerve monitor, for instance. So, and it's our job. There is no point in somebody doing 10 or 15 cases a year, and he gets complications. I think it is not right that the surgeons operate. It should be only the ENT surgeons. It's our job. This is number one. Number two, we handle the cases, and we still, if it's malignant, the pathologist in the cancer center still, and that's good, revises all the slides, all the specimens, because they are more experienced in the cancer center regarding the pathology. And again, to keep tens of surgeons doing the same operation, people here, this is a small population, this is a small country. They don't develop the proper experience. Experience comes with the number of patients, with the number of cases. The more you operate, if you are operating on a good and surgical basis, you will have the competence, you will be able to help, especially malignancies and especially papillary carcinomas. These are, malignancies that you get a good cure of it. This is a point has to be raised in Kuwait, actually. Thank you very much.
Thanks. I think it has to be raised everywhere, not only in Kuwait. I think this is quite a common phenomena, and I think it's quite clear now that really the more experienced you are in performing surgery, the less the rate of complications. There's no doubt about it. And then your patient will get educated. Previously, patient in UAE did not question the type of surgeon performing surgery. Now they ask, is that surgeon qualified to do thyroid surgery? This is the trend now. People are a lot more alert than before, and that's because the word is there, and then the intention is there really to identify people with really expertise and then give them the chance to get more expertise in that field. So your points are well taken.
Thank you.
Actually, this problem is, as Dr. Khalid said, is in the whole of the world. We have in Germany, the ENT surgeons operate the patients, the general surgeons operate the patients, and there is always a very hot discussion between both groups who should operate the patients. But we are going to make some rules in Germany regarding thyroid surgery, and we want that these patients be operated just by experienced surgeons who operate just the neck area. And it will be a new subspecialty in Germany, and we have some surgeons who operate just the neck area, the neck region.
I've got just one small question. What is your standard practice in Germany for I131 negative FTG positive patients? Do you opt for a systemic treatment with MKIs or TKIs, or do you go for these lutetium or yttrium-90 based therapies? Thank you.
Actually, there isn't any standard of operation in such cases up to. Could you repeat the question? Yeah, just because I understood that. You want to know what is our standard operation in patients with iodine negative, FTG positive cases. Do we send the patients to the internist for tyrosine kinase treatment, or we try to perform? Okay. Certainly, no. We don't send the patients to the internist, to internal medicine. Why? Because some of the patients can be operated. We send the patients to the surgeons. Otherwise, we try to find another possibility, because we are nuclear medicine physicians, but it is not the standard of operation. we perform an ocular scintigraphy, especially gallium-68 dot PET CT, and if it's very good positive, we try to perform radiopeptide therapy. The good news for you is that the majority of patients are not positive, and after that we send these patients to oncologists for performing a tyrosine kinase treatment.
My question is how the dietary instruction is important before the ablation therapy. Dietary instruction to the patient before and going for a ablation therapy of iodine 131.
I didn't understand exactly.
Dietary instructions.
Dietary
He's asking
instruction-
about dietary instructions.
Dietary instructions, how the low iodine diet, what are you any dietitian is in your setup, there is a dietitian come before instruction is given to the patient, how the low iodine diet is, how it is important, and how you evaluate these findings and how important they are.
Basically, your question, if just correct me, is how relevant is the education of patients on low iodine diet before they receive radioactive iodine treatment? That's the question? Yeah, I think probably you're adopting that, and people are following it here. The way that we have been doing it is that any patient coming in with thyroid cancer, and especially if they have to go for radioactivity, they have a checklist. And the checklist usually includes all people involved in the management of that patient. From the nursing, there's a nurse actually that we have identified as a nurse educator that really will make certain that the patient will give the patient all the instruction that the patient needs to receive to the patient and to the family before really receiving radioactivity. We have a video actually that we made about the isolation room where they can watch and then know what to expect, because that sometimes the idea of being isolated is sometimes could be scary for the patient. But surprisingly, I don't know whether really it's coincidental or not, all patients who have gone through isolation came up really serene, relaxed. Is it because of the hypothyroid condition or because they found themselves in meditation during those days? God knows. But the instruction is quite clearly given to them before really at least 1 month before they receive the radioactivity on the type of food that really are rich in iodine and the one that really they have to avoid in their diet.
In Germany also, from 4 weeks prior to radioiodine diagnostic or therapy, the patient, actually all patients are informed, and they know that they have to intake less iodine compared to normal life. Especially in Germany, fish is very important, and a very, very big problem are the multivitamins tablets in Germany. Some of them have iodine, and the patients don't know that, and they take every day, oh, I have cancer, I need multivitamins, and they take these tablets. But every time, 1 day prior to radioiodine diagnostic or ablation, we test the amount of iodine in the urine. And after that, we give the patients the capsule.
And I'm sure you know the product that they have to avoid is mainly dairy products, fish, eggs, all dyes that really contain the red color, some medication cough syrup that really contain iodine. Those are the most commonly really items that really are rich in iodine.
I want to comment on, just a comment on Kuwait experience in cancer center. I work in cancer center in 1988 up till today. I will tell you a brief how we are doing our things in there. Actually, from 1980, we have a problem that when we did the protocol, how we can convince people to change mind to do this or that. And for example, most of people at that time, they are doing simple mastectomy. How we can change their mind, especially the old people, to do modified mastectomy. So therefore, we collect a lot of people from 4 different major hospitals: surgeon, endocrine, nuclear medicine. We make a board, and then we put a protocol. At that time, we took the help from UICC and also from MD Anderson. And we study the protocol from both of them and their advice, and we came with protocol there. This protocol is updated every 4 years in our department. Not only that, it is not the problem to do a protocol, it is the idea how you can implement that protocol. This is why every week we have a discipline who are going to those hospitals and to tell them what you do with the patients, how you can treat thyroid. This is nothing to do, lipotomy, you should make total thyroidectomy for these cases. This is why we change the mind over at least 5 to 10 years to have the proper surgical treatment. So let us tell you, during my career there, we update the protocol from 1990 till the invasions 3 times, and after invasion we updated this way up to 1996. Then after that, of course, there is many people, they went from here, and there is a lot of expanding in the cancer. And this protocol need to be updated from that area. Now we have the Canadian people who come to us from McGill. There is a lot of revision of all our protocols, which is up to date. This is just a brief how we can deal with that. We have a lot of discipline, what Dr. Ali he said. We have surgical and cosmetic, we have ENT, radiotherapy building, etc., etc. For statistic, what he said here, I disagree with him because a statistic is well organized in KCC. It started in 1978 under UICC supervision, and actually we had a lot of effort on that and a big department on that. And if you notice the thyroid particularly, the incident of thyroid now became 4th and so as an incident, and before that was the 2nd. If there is anything related to hormone, it will stay in the front, not receding to the back. And we have initially, we have breast and colorectal and so on, prostate, and then thyroid is going down. But I don't think, in Kuwait at least, I can tell you, Iran is right. There is increased number, but this is according to the World Health and UICC statistic. That's what I want to say. Thank you.
So in 1986, when Chernobyl occurred, at that time, probably most of us were young at school. In 1986, when Chernobyl occurred, no one actually knew anything about the incidents until two weeks or probably 3 weeks later that they told the world that something has occurred. So probably some sort of political decisions might be taken in regard to the issue of whether there was any effect of radiation exposure during the 1990 on our population, and probably all we agree that statisticians can manipulate, they can display the other part of the statistics, and everybody would agree with me. So any